Okay, it's the magic hour, and we are here with 52 bills on our calendar. So we will convene the Health Subcommittee, and Madam Clerk, if you would call the roll.
Representative Boyd, Representative Byrd, Representative Freeman, Representative Hall, Representative Jernigan, Representative Kumar, Representative Marsh, Representative Ramsey,
Here.
Representative Sherrill, Representative Smith, Representative Terry. Chairman, we have a quorum.
Okay, does anybody have any personal orders? I think, did you? Okay. Do we have anyone that has personal orders here this afternoon? If not, we'll mount an attack on these 52 bills here. They're so chaotic about their status. We'll just go one by one. Item 1, House Bill 1202, has been taken off notice. Pardon me, roll to the heel. Item 2, House Bill 555 by Speaker Johnson. Had proper motion and second on the bill. You're recognized, sir.
Thank you, Mr. Chairman. House Bill 55 renews the annual allotment of 125 new Medicare skilled nursing facility beds through June 30th, 2025. It also removes some obsolete language and allows 3 years instead of 2 years to complete the new CON-approved project.
That being said, do we have any questions or comments of the sponsor? I did find it interesting. I've wondered how the COVID has affected the capacities in nursing homes, and I'm told that pre-COVID they were about 76%. Now they're about 64%. So we have suffered quite a loss, and we need to take care of these folks. Any comments or questions? If not, we'll be voting to send this bill to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you, Mr. Chairman. Committee.
Thank you, Speaker. We have item 3, House Bill 370, that has, there was an amendment untimely and one timely that was filed, so we're going to roll that to the heel of the calendar. We move on to item 4, Representative Lamar, House Bill 441. You are recognized. Motion. Have a proper motion and second on the bill.
Good evening, committee. House Bill 441 is a bill that creates a task force to study and report on preterm births and infant mortality as it relates to African American mothers. This bill is important because our maternal mortality review here in Tennessee found that African American women are 3 times more likely to die, and our children are 3 times more likely to die than any other race of women. In order to curb this issue and ensure that all women have equal chance at life and their children, we want to make sure we're studying on some of the factors that impact African American women that cause us to suffer such loss. I understand that we want to work more with the departments and figure some things out, so I would like to request a summer study, if that's okay with y'all.
If the chair will stand for a motion to summer study, we have proper motion and second. Any questions or comments as we send this important bill to summer study? If none, all those in favor say aye. Aye. Any opposition? So approved. You're recognized on item 5, House Bill 642.
Thank you.
We have a proper motion and second on the bill.
Thank you. It requires the department to create an evidence-based implicit bias training program for healthcare professionals related to maternal and infant mortality. And I'm just wanting to read a couple of startling facts to you, which is why I'm pushing this particular bill. A 2016 study found that nearly half of its first and second year medical students believe that Black people have thicker skin than white people and perceive Black people as experiencing less pain than white people. An idea born from the 19th century experiments that were conducted by a physician named Thomas Hamilton. He was a wealthy plantation owner who regularly tortured and enslaved black men named John Brown, creating blisters all over his body in an effort to prove Black skin went deeper than white skin. A 2019 study published in the American Journal of Emergency Medicine analyzed data from 14 previously published studies on pain management and found that Black patients were 40% less likely to receive medication for acute pain compared to white patients and 34% less likely to be prescribed opioids. What we do know is that the African American community is always on the negative end on any other health outcomes in this state. That is a problem, and we want to ensure that our doctors are knowledgeable and aware of many of the diseases and the socioeconomic impacts that African Americans go through that impact our health. So in order to do this, we want to implement implicit bias programs to provide training for doctors and medical professionals so that they're aware of the cultural implications that individuals in our state have so that we can care for our patients and meet them where they are so they have equal chances of living, receive equal healthcare treatments. But I also understand that a lot more people want to take part of this conversation. So if it's okay with you, I want to really push this issue. Again, we found that Black women are 3 times more likely to die than white women, and we want to make sure that we have a chance to live as well, and that requires holding our doctors accountable as well. So in order to let everyone be a part of this discussion, I would like to motion that I receive a summer study.
Okay, we join you to our committee, and as a member, we have a motion and second on that, and these are extremely important issues, very timely issues, and we want to be a part of the discussion and a part of the remedy. So if no objections, we'll be sending this bill to summer study. And you are recognized on House Bill 459, number 6. Have a motion and second on the bill.
Thank you. And as the committee, see, y'all understand I like health care and I'm very interested in health care, being that it's my 3rd bill in front of the committee today. But with that being said, I'm changing the course and I'm focusing on human trafficking with this particular legislation. We want to ensure that our medical professionals are adequately trained on human trafficking and how to deal with human trafficking victims when they come into the emergency room. Now, what we do know, a lot of human trafficking victims are scared to go to the emergency room because our medical professionals don't necessarily know how to deal with them. We have issues with our rib kits. They are scared of their perpetrators or find out they're going to seek help. We could potentially send them back into the arms of someone who harmed them or send them into the justice system when they really need some other form of help. So my bill is to make sure that our medical professionals have the adequate training to deal with the human trafficking victims, but I also understand there are more people who want to be involved in this conversation. So I would love to entertain a summer study.
Okay. And thank you very much. Any questions or comments? The summer study has been moved. And these are important issues. I've noticed that several of the health professions have required continuing education specifically for this last subject that you've addressed. So we look forward to being a part of your discussion and helping for meaningful efforts next year. So if there are no objections, we'll be sending this to summer study. Yes, ma'am, you're recognized.
And thank you. I want to say thank you to the committee. I would love for all of y'all to participate in the summer study and give me your opinions and contribute. And then to all my healthcare professionals in the audience who are listening and are interested in any of the things that I'm talking about, again, would love for you to take part in my summer study. And I hope that you contact me in advance so that I can bring you in on this. So thank you, committee, and I appreciate your support.
And thank you, Representative. We go on to item 7, House Bill 1356, and I'll recognize Chairman Terry to turn the gavel over to you, sir.
Thank you, Chairman. You are recognized on House Bill 1356. You have a motion and a second.
And thank you for the motion and second. This bill enacts what we have named the James Dustin Samples Act. And what we are trying to do with this legislation, we brought it up last year, and it moved on ahead. The bill creates a legal presumption that a firefighter diagnosed with post-traumatic stress disorder by a mental health professional, the consequences incurred the injury in line of duty. Under this presumption, the injury will be compensatable under the workers' compensation law unless it is shown to be a predominance of evidence that the post-traumatic stress disorder was caused by non-service connected risk factors or non-service connected exposure. As we see, the majority of the situations that the firefighters are involved in really reflect EMT and health issues, and these are very stressful, very traumatic, and they are exposed to many times the normal level of these instances that the average public or even some other first responders are subjected to. The bill applies to any firefighter who is diagnosed with post-traumatic stress disorder within 3 years of the firefighter's final date of employment with the employer fire department. So that being said, I think we have someone to speak. Maybe. Oh, I'm sorry. I thought we had someone to speak about James Dustin Samples. He was a young firefighter that took his own life, and it reflects the issues that we face today, where many of these firefighters not being presumed to be in the difficult situations that they are, that they hide evidence of post-traumatic stress, and so sometimes it can, and has often almost 3 times the rate of average citizens, often drives them into taking their own lives. That's what this bill is about.
Representative Hall, you recognize?
Chairman Ramsey, I want to thank you and for bringing this legislation forward, and I applaud your efforts. Dustin Samples was a good friend of mine that suffered in silence and fell through the cracks and didn't get the proper help that he needed. And I applaud your efforts, and this is good legislation here. And I just thank you for bringing this forward.
Chairman? Okay, no further questions. Question's been called. Without objection, we are going to vote on House Bill 1356. All those in favor say aye.
Aye.
Opposed? Ayes have it. Bill goes on to full committee.
We're on to item 8, House Bill 967 has been rolled to the Hill. That is by Representative Carringer. Item 9, House Bill 1088 by Representative Hakeem. You are recognized, sir. Second. Have a proper motion and second on the bill. And I think, do we have an amendment? Oh, no amendments.
Sir?
You escaped, sir.
All right. Thank you, Mr. Chairman and members. What our bill does, what's concerned about, is that with the acceleration of the COVID-19 pandemic, there's been an acceleration in opioid overdoses in the metro Nashville area, 619 suspected fatalities related to that. And as a result of COVID also, we've had a large number of people who would normally be in a homeless shelter who are now, because of COVID, they're going into parks and places of that nature. And this is in particular in the 4 major cities in our state. And what this bill would do is, it's against policy at this time, against that needles would be afforded to persons within 1,000 yards, I believe it is, 1,000 feet of a park. that we're not dealing with schools, but dealing with parks. And what this would do is to allow those entities or agencies that provide syringes and so forth to persons in the parks, with the intent being to lessen the HIV and other transmittable diseases that take place when people congregate in that manner. And this, well, you might be right, Mr. Chairman, about an amendment. This would be repealed in December of 2023.
I think that may be in the bill. I don't think there's an amendment. Is that in the bill?
Okay.
Oh, it doesn't have a sunset. My knowledge, that doesn't exist in the
Okay.
bill.
All right, we're good with that.
You said it had a 2-year sunset.
Yes, sir. Yes, sir.
We can't find it. If that's your intent, we can propose an amendment before it goes to the full, but
Yes, sir.
if I don't know that
We'll
anybody's-
clarify before,
Okay.
if you all, the committee allows it to go to full.
Sure.
We'll clarify this
Okay.
as we go to
Do
full.
we have any? Pardon? Oh, I'm sorry, that was put on in the Senate.
Okay,
Yes, sir.
okay.
So, do anybody have any questions or comments on the bill? Dr. Kumar, I see your hand, and Dr. Terry.
Thank you, Mr. Chairman. Thank you, Representative Hakeem.
Yes, sir.
So I assume that there is an existing program for needle exchange in these areas, and that is conducted by nonprofit voluntary organizations?
Yes, sir.
And what was the reason that the restriction was put on about certain distance from schools and so forth?
Well, concern about this taking place near, let's go with a school. Something could happen in regards to children been exposed to this or accidentally, stepping on a needle or something of that nature. So we're not dealing with schools. We're just dealing with parks. And in a sense of speaking, that has been taken over by persons who are displaced from homeless shelters and so forth. And so these are areas where persons congregate who are homeless, and there's been a higher increase dealing with hepatitis and HIV as a result of this. And the belief is, and the history shows, that these people are using the same needles. And this effort would be to avoid that or keep that from happening, providing, we say, new needles or clean needles.
Dr. Kumar?
Yeah, what I'm searching for is that the restriction about distance from these parks area was put in. And what was the reason for putting that restriction? And has that restriction not been helpful, or has the situation changed that we want to remove the restriction?
Representative Hakeem?
Thank you, Mr. Chairman. Because of COVID, people were moved out of the shelters, and they started to congregate in the parks. This is in the major cities. And so this is what has changed. And what is happening in those areas is that an increase in HIV and other infections and so forth. And the effort is to limit as best possible those infections. And the belief is, and the history shows, that clean needles would avoid this. Now, again, this is not near schools. This is areas, I'll use the term, that have been designated for persons to go to that are homeless at this time. I'm sorry.
Dr. Kumar?
No, thank you, Mr. Chairman.
Yes, sir.
Dr. Terry?
Thank you, Chairman. I'm just trying to get clarification on this. So it's, the bill would authorize a needle exchange program to be conducted within any distance of a park, but not a school.
Correct.
Correct, okay. And so currently it's 2,000 feet except for Chattanooga, Knoxville, Memphis, and then it's 1,000 feet school and park. So this is strictly for Davidson County, Chattanooga, Knoxville, and Memphis,
That's it.
no school, and it's for a park for a sunsetted period of time.
Yes, sir.
Representative Hakeem.
Thank you.
Chair Lady Smith, you want to be recognized?
Yes, sir. Thank you, Mr. Chairman, and welcome to health, colleague.
Yes.
I'm just curious because we're from the same area. And so just to walk me through, so at Coolidge Park, we could do a needle exchange program.
Well,
Representative Keen.
thank you, Mr. Chairman. I don't believe we would utilize a place like Coolidge Park. If I'm understanding correctly, homeless have not, in a sense of speaking, taken over an entity like Coolidge Park. But there may be in a community or neighborhood around, we'll say the downtown area, that this is happening. What street is that? The 11th Street area, there's a problem near the community kitchen, places like that. Yes, ma'am.
The Chair Lady.
Yeah, and again, I'm just trying to understand because I think while we're trying to meet a need, we're also trying to avoid an unintended consequence. And while, the predominant number of people that are going to be at a park, whether it's on 11th Street or at Coolidge Park, or they're going to be kids, they're going to be families that are seeking green space. And I don't know that we want to turn an open green space into a facility for something as invasive as a needle exchange. I'm not saying that that's inappropriate because I know right beside Patton Towers, which unfortunately just got condemned because of fire, there are mobile units that are available, and I wonder if it wouldn't be better to engage with certain health entities on a mobile temporary basis to go into areas and rather, than parks, try to meet people at the homeless kitchen or the shelters. Thank you, Mr. Chairman.
Representative Hakeem.
Thank you very much. Well, as I said, to my knowledge and understanding, entities like Coolidge Park and others of that nature are not considered in this. And then we would have the county and the city having input into something like that being done. And the only area that I'm familiar with right now where this would take place would be in that 11th Street area, in the area near the community kitchen where people have camped out, that type of thing.
To have further questions or comments of Chairman Terry, you're recognized.
Thank you, Chairman. And Representative Smith actually brought something up that I would hope that maybe be considered as opposed to, I know this would be temporary, and talking about mobile, there being a difference between a physical building versus someone that's doing outreach in the park. And maybe that may be something to consider as opposed to, as this is structured, this bill is structured, it would be, they could have something right there at the park. Maybe it's, keep it 1,000 feet, but they may enter the park, or you may have outreach into the park, or maybe 500 feet and outreach into the park. Just something for the committee to consider, that we keep the actual facility or whatever away from the park, but you allow the outreach in there. That may be just something to consider.
Representative Hakeem.
Yes, sir. I'm sure that's something that could be explored as far as the mobile piece, but as you spoke of, the outreach would be entities or agencies going into these areas. And when we talk about parks, we're not talking about where families and children are. We're talking about essentially where people have set up camps, so to speak. And that, well, I guess it's an area I wouldn't expect families and children to be, if you follow me.
Dr. Terry, further comments?
Thank you. I understand where you're going with
Yes,
this,
sir.
but what it reads versus what the intent is, I just throwing that out there for consideration.
Yes, sir.
We have further comments or questions of Representative Hakeem? If not, we will be voting to send this to full committee. All those in favor say aye. Any opposition? So approved.
All right.
And
Thank
I would note that you can carry your bill forward without the sunset on it.
Yes, sir.
And then conform to the Senate bill, and or else you can amend it in the process the same as the Senate.
Thank you very much, Mr. Chairman
sir.
and members.
We'll move on to item 10, House Bill 1489 by Representative Towns. Is it all three? All three of them. I've been notified that item 10, item 11, House Bill 1495, and item 12, House Bill 1494 will all be taken off notice. We're on item 13, House Bill 710 by Chairman Hurt. You're recognized. Have a proper motion and second. Yes, sir, you're recognized.
Thank you, Mr. Chairman. House Bill 710 looks to address some complications with certificate of need on hospitals or institutions that are reopening after being closed. Present law generally requires that a person obtain a certificate of need before establishing a healthcare institution, changing the bed complement, or instituting certain healthcare services. This bill creates an exception to present law whereby a certificate of need will not be required for a licensed hospital if, number one, the hospital was previously licensed or another hospital was previously licensed at the proposed location. Number two, the hospital is located in a county that has been designated by the Department of Economic and Community Development as a Tier 2, Tier 3, or Tier 4 enhancement county, or that has a population less than 49,000. Number three, the last date of operation at the hospital site or service area, proposed hospital site, was no more than 15 years prior to the date on which the party seeking to establish the hospital submits information to the Department of Health pursuant to this bill, and the party seeking to establish the hospital applies for certificate of need from the Health Services and Development Agency within 12 months of the date on which the party submits information to the department pursuant to this bill. This bill is to make it easier for our rural hospitals that have closed, that have parties coming in that are looking to reopen them to help expedite the reopening of those hospitals. And with that, I'll take any questions.
Okay, do we have any questions or comments of the sponsor? If not, there are no amendments. We will be voting to send this bill to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you, Mr. Chairman and committee.
Yes, sir, thank you. Okay. House Bill 14, item 14, House Bill 460 is off notice. Item 15, House Bill 449 has been rolled to the first calendar of 2022. No objections? We need to make that official. Okay, we need to make that official, don't we? Okay, no objection to the first calendar of 2022, so approved. Item 16, House Bill 1240, I think, okay. 1240 by Representative Parkinson has been rolled to the heel. I don't see him here. Item 17, House Bill 1156 by Leader Stewart. You're recognized, sir. You have a proper motion and second.
Thank you, members of the committee. And I'm going to take this off notice, but I'd like to mention what I'm doing because you'll hear me back again. This is actually a very important bill, and I think one that can ultimately become legislation. We have multiple centers of medical learning in the state of Tennessee. Two are very involved in research of pediatric rare diseases, St. Jude's in Memphis and Vanderbilt here in Nashville. And they are part of a series of consortia that deal with these rare diseases. There's a real problem that rare diseases present, and it is that researchers have difficulty accumulating the data points that they need to make reasonable decisions. When you're talking about things that we all get, like heart disease, there are millions of people that get it, and it's deeply studied. When you have rare diseases, it's hard to accumulate that information. It's still widely recognized that developing systems to sort information about rare diseases is really needed to facilitate the study of these diseases. Just recently, in July 2019, in the Journal of Rare Diseases, the authors from all across the world called for appropriate legislation to further the information sharing among these critical institutions. So, I believe that we in Tennessee can create a statute that can then become a model statute that states can pass to create the legal infrastructure that makes it very easy for these major healthcare institutions to share information. And I'm taking this off notice so that I can work further with St. Jude's, Vanderbilt, and any other medical institution in the state that wants to see if we can develop legislation that meets all the scientific needs and the needs of patients. So you'll be hearing from me, and I thought since I had the opportunity to address the committee members, I would do that. But like I said, it's not ready. I think those institutions need further buy-in, and so I'm taking it off notice, and I look forward to talking with you again about it.
Chair Lady Smith, you're recognized.
Thank you, Chairman. I'm just curious of the sponsor. How does this, within the last 2 years, we formed the Tennessee Rare Disease Advisory Council with the state, and it was charged specifically to work not just with the pediatric space, but throughout all ages, and devoted to make seamless the treatment and the study. Is this not a redundancy? Thank you, Mr. Chairman.
No, it's not. The advisory council is there, as I understood it, and I was very focused on that when that legislation was passed, is there to essentially, as many advisory councils are, to create the most seamless, effective approach to treating these diseases in the state of Tennessee. In other words, make sure all the institutions are talking to each other, the resources are properly allocated. I view that as mostly an intrastate issue. This is different. This is about these institutions that specialize in rare diseases transferring institutional information among states and across national borders. So I think it's a different thing. Obviously, the advisory council would have to have its opportunity to speak if, in fact, this bill got legs and we were talking about moving legislation. So I think this legislation seeks a compatible goal, but with a slightly different focus.
Chair Lady, do we have any other comments or questions of Leader Stewart? If not, no objections, we will take this bill off notice.
Thank you.
Thank you, sir. And we move on to item 18, House Bill 807 by Representative Powell. You're recognized, sir. Have a motion and second on the bill. I think maybe we have one or two amendments that have been proposed.
Yes, sir, Mr. Chairman. I'm at the will of the committee, but I do plan on taking this bill off notice. However, I would like to adopt one of the amendments, and I can explain the amendment because I think it's just an important component as I continue to work on this piece of legislation. Yeah, the amendment that I was hoping to get on is 5837.
Okay.
And the amendment just cleans up previous fiscal note and ensures federal compliance with the SNAP program.
Okay. Let me get a motion and second on the amendment. And we have a proper motion and second on the amendment. Do you have further explanation?
Sure, Mr. Chairman, and just on the amendment, like I said, I do plan on taking this off notice if I could get this amendment on. Essentially, the way in which 40 other states have increased or eliminated asset limits within the SNAP program is by implementing broad-based categorical eligibility. Broad-based categorical eligibility is simply the federal process that states must go through by which asset limits of the SNAP program can be changed. Again, I just would like to get this on and then work this bill next year.
Okay, with the request of the sponsor, we'll be. Oh, I'm sorry. Did you have a question on the amendment, Chair Lady Smith?
Help me on this. So we're taking a taxpayer-funded program that's meant for the needy, and we're moving the metric of measurement, the means testing.
So we would be adding in this broad-based eligibility, which is a component adding in that the federal would also consider that 40 other states do. And the hope is, and essentially what this bill gets at, and I can speak to that, but is looking at asset limits for TANF and SNAP. My hope is that a lot of people that are in these programs is to establish and work towards savings so that they're not punished for trying to get out of their own situation and they can work towards savings. And so we've had some pretty good discussion with the administration about that, and I realize there might be some philosophical differences, but again, that's what that amendment does.
Okay, Chair Lady Smith.
Yeah, thank you. And we agree that I think that we can do a better job of using TANF and SNAP to bridge that benefits gap. I think we're talking the same thing in the same population, but I don't necessarily feel good about removing one of the key measurements as far as income and adopting, let's put it this way, things that happen in Washington, D.C. have not proven to be very effective here in Tennessee. But to that point, thank you for clarification, Chairman.
Yes, further comments or questions on the amendment? If not, we'll be voting on the amendment to place it on the bill. All those in favor say aye. Aye. Any opposition? So approved. We're back on the bill as amended. Do we have further comments or questions on the bill? If none, we will, if there are no objections, we will take this bill off notice.
Thank you, Mr. Chairman.
No objections, the bill as amended is off notice. That takes us to item 19, House Bill 920, and I'll turn the gavel over to Dr. Terry.
All right, Chairman Ramsey, you're recognized on House Bill 920. You have a motion and a second.
Thank you, ladies and gentlemen. This is a bill that I would prefer that we refer to as the cerumen bill instead of earwax. What this bill does is add cerumen management to the authorized scope of practice to be performed by licensed hearing instrument specialists under the Council of Hearing Instrument Specialists. Requires a licensed hearing instrument special to follow regulations established by the council regarding cerumen management, to carry appropriate professional liability insurance before performing the removal, and maintain proper infection control practices. And I would like to submit an amendment 6203 to that effect.
Okay. You have a motion and a second on 6203.
And that amendment makes the bill. We have discussed this at length with professional organizations, the Tennessee Medical Association, and they had some very valid requirements that they placed on the bill in this amendment, and we were happy to conform to those. And so it would be my desire to place the amendment on the bill that makes the bill. So with that said, sir.
Okay. Any questions on the amendment? Okay. See, Chairman Kumar, you recognize.
I'm sorry, the amendment number, I'm not clear. I have 5924.
Chairman Ramsey, you recognize.
Sir, there was a previous amendment. There was still some issues that the Tennessee Medical Association had, so we redid the amendment, and this is the current amendment that makes the bill. I got a physical memo on it. Okay,
Chairman, you recognize.
Mr. Chairman, I'm told that the preferable amendment was the previous amendment, 5924.
Chairman, was 6203, was that in our amendment pack? I'm understanding that's the amendment that was worked out, but it may not be in our amendment pack. So if that's the case, was this a timely filed amendment? And if that's the case, then we have to do some procedural motions.
I have been told all along that it was timely filed, and I have the fiscal memo on it. So I plead ignorance. I'm left with
Okay.
misunderstanding.
Unless there's an objection, we're going to vote on 6203.
That would be my
Okay.
preference.
Okay.
That's the TMA.
Okay, without an objection, we're going to, Chairman Kumar?
I'd just like to note that that amendment is not in the system. It's not on the marked calendar, and that means that we have not seen it. The members who are going to vote on it have not seen it.
Well, I've got it here, printed out with the Chair, oh, I'm sorry, go ahead. What the hell? Rochelle?
Do we need to reconsider action?
We don't need to reconsider anything, but this would be.
Does he? All right, without objection, we are going to roll House Bill 920 to the Hill.
We will move on to item 20, House Bill 880 by Chairman Terry.
Thank you, Chairman Committee. This bill does exactly what it says it does. However, the Senate is looking to amend it, and it's on their calendar for tomorrow. I'm at the will of the committee. I'm willing to roll this to see what action they take. It's up to the committee. I can present it, or we can roll it.
Do we have any desires from the committee? With no objections, we will roll that bill to the Hill. Is that appropriate? No objections. We move on to item 21 by Representative Freeman. We have a motion and second on the bill. We have an amendment, I think. We have a motion and second on the amendment. Does the amendment make the bill? Okay.
Yes, sir.
Let's go ahead and put the amendment on the bill. All those in favor of the amendment say aye. Any opposition? We're on the bill as amended. Would you like to explain the bill as amended?
Yes, sir. Thank you, Chairman, Committee. For several years, child care, early education providers, and members of the Tennessee Association for Children's Early Education have been unable to get consistently reliable and prompt information from the Department of Human Services about policy changes, grant operations, and related issues. This bill simply clarifies that we're going to have a point person in that department that can answer these questions. It also clarifies that it's not going to require a new staff person, and that they will have one point of contact that they can help direct their questions to. And this bill came about during the pandemic, when we were asking child care services, early educational providers to provide care for members of our community who were working in hospitals and other places doing great work. And the providers couldn't get answers on the specifics of the program that they were being asked to operate in. They were literally going to the website, hitting refresh all day long to get updated guidance. And so all they want is to have one person to direct these questions to that can help them answer them. So with that, I ask for your support.
Do we have any comments or questions on the amended bill? If none, we will be voting to send this amended bill to full committee. All those in favor say aye. Any opposition? So approved. We'll move on to item 22, House Bill 577 by Chairman Reagan. Sir.
We need to actually pass the amendment. We just put the amendment on the bill. We need to pass the bill itself as amended. Thank you, Mr. Chairman and committee.
On the bill before.
The administration has brought me an amendment on this. I request to roll it to the heel because they have not yet completed their work on it.
On the bill. Have a motion and second on the bill, and I think your request is to roll it to the heel.
Yes, sir.
No objections, we will roll this bill to the heel. We'll move on to item 24, 575. You're recognized, sir.
Mr. Chairman, I also request to roll this one to the heel. Different rationale this time. This bill is in reserve for Chairman Zachary's bill going forward. If his bill goes forward, this one is probably going to be unnecessary. On the other hand, if his doesn't, I'm going to run this bill, so I request to roll it to the heel as well.
Okay, and let me make a correction. I introduced item 24. Actually, this is 23, 579. Is that correct, sir?
I'm going to run that one.
Okay, let's go back to item 24, House Bill 575. You have asked to roll to the heel.
Yes, sir.
Yes, sir. No objections. We will roll that bill to the heel. We're on item 23. That's House Bill 579. Yes, sir, you're recognized.
Thank you, Mr. Chair. Currently, the Department of Health has inadequate information on measurement system quality standards for all the labs with which they work. There are some 330 labs in Tennessee. All of the labs are certified under CLIA or equivalent certification criteria. However, this particular situation arose back during July of last year. The pandemic had...
Let me interrupt you just a second. Let's get a proper motion and second on the bill. Have a motion and second. Yes, you can go ahead, sir.
Okay. This particular arose in the summer of last year after the pandemic peak had arose, and I sent a letter to the Department of Health asking what the rate of false positives and false negatives were in the testing that was being used. And I got the old round-shouldered salute.
I don't know what that is, but go ahead.
The idea is that they were making recommendations to the governor for decisions that were affecting our entire state without giving the governor all of the information that was necessary to make an informed decision. I'm not quarreling with the idea that they make recommendations. That's not part of the bill. But on the basis of testing, and by the way, if you want a statistical discussion, I'm glad to give you one. But what it boils down to is when you're testing individuals that already show symptoms, you get a very low rate of false positives. When you're using the test as a screening device, you get a much higher rate of false positives. At the time I wrote the request to the Department of Health, there were several studies out there that had caused me to write that question to the Department of Health. And those false positive rates, one of which was put out by the CDC, was 6%. Another one, which was put out by another very highly recognized and prestigious organization, was as high as 26%. And what that boiled down to, ladies and gentlemen, is that we had as many as 60,000 people in our state at one time that were told they had a positive test. And of course, the fact that it wasn't positive was good because they didn't develop the disease. However, they were quarantined. They were not producing economic output for our state. So we, as a state, suffered economically by virtue of having all these people. And by the way, that number went up as the number of tests went up. So suffice it to say that I don't know that I would have made a different decision had I been in the governor's chair and given the information he was given, but I think he was not given enough of the right information. I will specify, too, that this bill requires no change to current law and that test results that are asked for from these labs still go directly to the requesting healthcare professional. There's no intent to change that. And there's no intent to change the fact that each of these healthcare labs do their own quality control measures, in most cases on a daily or more frequently basis. The idea, though, is that our own Department of Health has no real handle on what these are. So this bill requires that a report be made oh, by the way, Mr. Chair, I'm sorry, there is an amendment on this. I've just explained the amendment.
Does the amendment make the bill?
Yes, sir, the amendment number is 4495.
Let me get a motion second on the amendment. We have proper motion second. Let's put the amendment on the bill. All those in favor of amending the bill so stated, say aye. Any opposition? We're back on the bill as amended. I think that's what you've been describing.
I've been
to us.
describing the amendment.
Yes,
My
sir.
apologies, sir. The idea behind this is to create a mechanism whereby our state agency has an idea of what the medical laboratories in our state can do. Now, there's been some misunderstanding that went as far as Washington, D.C. I got an objection memo from a Board of Pathologists group in Washington, D.C. The misunderstanding that they had was in the bill it specifies a statistically valid sample plan. They were operating under the impression that the millions of tests done by these medical laboratories would all have to be sent to the state, cataloged, and examined. Again, they did not understand, in fact, that's on page 2 of the amendment, that it requires a statistically valid sample. As someone who earned a living in the field of statistics, I can tell you it's possible to create a statistically valid sample with as few as 100 samples. So we don't need millions to characterize this. The labs are already doing these tests anyway. This is merely a method of consolidating these reports so that we know, as a state, through our health department, what the medical capabilities of our labs are. Right now, it's assumed, probably not a bad assumption, but I learned a long time ago in the military that you don't assume things that are critical for life. And therefore, I think our state needs to be aware of what these are. I will point out also that, again, the idea here is not to measure every test of every laboratory. A statistical sample, which is far cheaper and far easier to do. And it would also provide the Medical Laboratory Board, which is in charge of doing this, the means for doing that. They are a fee-supported organization. No money comes out of the General Treasury for this. With that explanation, I stand ready to answer questions.
Okay. Do we have any, yes, Representative Speaker Marsh?
Thank you, Mr. Chairman. And Representative Reagan, how would they know if it's a false positive? I mean, if you've got a certain percentage that are false, but you've got the possibility of the false ones that are actually false, are positive, I mean, spreading the disease, looks like to me you wouldn't have a choice at that time. You got to, if it's positive, then you got to act right then. You can't assume that it's a certain percentage positive. How do you recommend we deal with that?
Thank you for the question, sir. Metrology was my field of specialty in statistical analysis. There's a number of ways you can do that. The easiest way is something called split sampling. When you get the sample, you split it in half and you test it twice. Different machines, different people, or different labs. And then if the result comes back different, one of them is obviously false. If it comes back the same, you can assume it's a true result. You can also double sample. There's a myriad of techniques that you can do which do not delay and provide the opportunity for us to see that. Now, by way of example, there's variation in all things, even at the atomic level. For example, you've heard of carbon-14 dating, but if you look on the periodic chart, carbon is 12. So if you have variation in the atoms, from carbon, and for example, and 12 and 14, you have variation in everything, including measurement systems. So the way you test that measurement variation is you measure something more than once. You will never get exactly the same answer if you do your system is messed up. But to see how close you get to the same answer is the goal. And in the case that we were talking about here, that methodology is simple, straightforward, and again, I want to emphasize a statistically valid sample. That is to say, the millions of tests that are done, all of them don't have to be done that way. You do random selection, which any statistician will tell you is the key, random selection of various labs and various samples, and ask them to do a split sample or double sampling or a bunch of other techniques, and report that to the central organization.
Speaker Marsh?
And I understand that you could do that, and I see what you're saying, but we were under a really critical time frame with this disease, and we had to have it tested. I mean, I was frantic to get a test a couple of times, and I didn't want to wait, the couple of weeks to get the results back. I wanted to know whether I should quarantine or keep working. So I just don't understand how you can do that quickly, I guess was my question.
Chairman Reagan.
Okay, when you split the sample, you run them simultaneously. You run them in parallel. There is no delay. As long as it takes to run one test, the other test is running right beside it.
Speaker.
Would it cost double to do the test then?
It depends upon how you mean double. You're going to get the sample anyway, so the cost expended in getting the sample is the same. The parallel running, yeah, you're going to pay for that. But again, a statistical sample, like I said, 100 can characterize millions. And by way of example, I would invite you to consider what they report on elections. Millions of people vote on an election, and they put out a statistical sample. Usually they sample like 800 people to predict the behavior of the millions of voters across the nation. So a statistical sample will accurately predict the millions of results. The important piece that is missing here is our governor was told that we have this many positive tests, and therefore we must do something. The governor had to make a decision. But he was not told that out of these tests, anywhere between 6 and 26% were false positives. Now, there was also some false negatives in there. Don't misunderstand me. You can have two alternatives. We're not so much concerned with the false negatives. The false positives are the ones that we reacted to. And for that reason, I think that the governor making his decisions would have benefited from having that information. It may not have been a different decision. Don't misunderstand me. But not having that, to me, is a critical piece of information for that decision that was missing. Had I been sitting in his chair, I would have wanted it. And I think he would have too if it had been available.
Speaker.
Okay, if we pass this bill, what will it look like?
As far as
As our testing, is the way it was done versus the way you think it should have been done.
Chairman Reagan.
Thank you. The Medical Laboratory Board is authorized under this bill to create rules, promulgate rules to set this procedure up, and it's fairly straightforward to do so. I could have done this in the bill for them. In fact, the first version of the bill that I wrote was intentionally vague to give them as much authority and latitude as possible. But the complaint I got from the pathologists and some others was it was too vague. So it's now in there, but I've still left it as flexible as possible for them to be able to choose among the many ways that they can do this to implement it. Now, if you want to get to specifics, we can talk about the PCR test, the number of revolutions and so forth and so on, which I don't think is something we need to get into. That's in the weeds. The idea behind this is we have a metrology, a measurement system across the state, 300 plus labs, and we depend on those labs giving us results. The labs themselves do quality control measures. They keep them internally. We're not asking them to do anything extra in that sense. We're asking them to send that information forward, and we're asked by the metrology board, or pardon me, not metrology, measurement, medical laboratory board, to set up a sampling mechanism that's statistically valid for double sampling.
Speaker. Okay. Representative Freeman, you're recognized.
Thank you, Chairman. And I'm kind of along the same lines. I'm a touch confused because my understanding is when a test gets approved for use, that there's an efficacy report that talks about how what the likelihood of a false positive is. I know every test that I took, I was told that there is a certain percent of false positive, false negative, whatever you want to call it. And so I guess I'm not totally sure what you're asking for, how that would address it, because if the test in and of itself has a built-in range of false positives, how would running that test multiple times affect the validity of a test?
Chairman Reagan.
Thank you. I hate to disillusion you, but the information you were given was based upon the manufacturer or the creator of the test. They set the test up, they ran it once or twice, and they said, this is what it is. I made a living for 2 decades working across all industries, including healthcare, going into many cases really advanced labs, and finding out that the information they were given about the effectiveness of the various tests they were trying to run were not exactly what the manufacturer told them. Like I said, there's variation in all things. If I were to give you a yardstick and say, measure the length of this table, you give me a number. If I had the same yardstick to another person, measure it, they're going to give me a slightly different number. There's going to be variation. Yet I could tell you with certainty that the length of that yardstick is 1 yard. So you're going to ask, how can we get different measurements? Unless that is exactly the length of the yardstick times twice, they're going to have to interpolate and measure between. So you're going to have variation. And the same is true even with very sophisticated lab instruments. Some of my clients, when I was consulting, included United Healthcare, the world's largest health insurance company. I worked with a number of medical, Merck Sharp and Dohme pharmaceuticals. So when I tell you that there's variation in their labs, I've seen it. It's not like I'm making this up. The idea is that that variation exists, and we, collectively, as decision makers, but more importantly, the governor needs to know that. And this bill is about getting that information put forward.
Representative Freeman.
Thank you. And you kind of hit on exactly what I'm saying. A yardstick is a set length. The test has a variation within it. And so I guess I'm not understanding how running the test multiple times, knowing that there's a variation within the test, and again, you said it yourself, if the test is actually not as effective as they're saying, or the results are not as valid, how would running the test twice change any of that? How are we getting to the crux of what you're trying to do, which is a percent of false positives, false negative, whatever the reporting is?
Measurement system variation.
Yeah, okay, thank you. How are we going to ever get there with a test that you, by your own statement, is not a valid test? I mean, we're not going to get to that number in my head. Maybe I'm not smart enough to figure that out.
Chairman Reagan.
All right. In the absence of a whiteboard or screen, I will ask you to trust me when I tell you that Bayesian analysis combined with some other statistical techniques will enable you to get there, okay? And as I mentioned, the idea of testing people who are showing symptoms with the kind of test you're talking about, and by the way, that's what they give you. Testing people that are showing symptoms yields a low false positive rate. When you're using it as a screening test, which is what we did, that's what those 4 studies that I referenced pointed out. The lowest was CDC, believe it or not. They said 6%. And these others ranged between 6 and 26%. Now, that may come as somewhat of a shock if you're not used to thinking in those terms, but the idea is there is variation even in measurement systems. And what we need to know is what that variation is, so that when we make a decision, it's that yardstick analogy. If I were to lay the yardstick out there and measure and tell you that that table is 2 yards long, plus or minus a 1/4 inch. Someone else measures it and they say, no, it's 2 yards long plus or minus a 1/2 inch. There's the variation in the measurement. But if I tell you my yardstick is perfect, it measures exactly 1 yard, that doesn't change the fact that when applying that test, you have variation. And you need to know what that variation is when you're using it to make decisions. The fancy lab equipment, I have nothing against. Don't misunderstand me, it's really good stuff, but even it has variation.
Chair, Representative, Dr. Terry, you want to be recognized?
Thank you, Chairman. I'm just trying to wrap my head around all this and trying to put it in some terms that I'm familiar with, which I don't know that other than maybe a couple of members may. There is something, a lab that is drawn called a prothrombin time, PT, and there's a lot of variability in lab. And so they came out with something called an international normalization ratio, to where those numbers may be elevated at one facility versus another facility, and that may change what I do from an anesthetic standpoint. I may not do a spinal anesthetic. But now that it's normalized and you have that information, it provides more accurate data. And so I'm trying to figure out, is that what you're trying to get at, is something along
Chairman
those
Reagan.
lines?
In a sense, yes, sir.
Thank you.
Not exactly as you described it, in the same sense.
Further comments or questions? Chairman Kumar, you're recognized.
Thank you, Mr. Chairman. Thank you, Chairman Reagan. I wonder if it's possible to simplify a complex subject. In the sense, what we are saying is there is variability in testing. No test is perfect all the time. The decision maker who's going to make key decisions that affect public health, based on those reporting, should know the variability, how bad it is. Is that what we're trying to say?
Yes, that's correct.
Thank you.
And further comments or questions, we have had offer of testimony from a member of the audience. If we don't want that, we will pass it on by. Further comments or questions from the committee? If not, we will. We're voting on the amendment, the bill as amended, to send it to full committee. All those in favor say aye. Aye. All those opposed? No. Sorry, your bill fails, sir.
Thank you, Mr. Chairman of the committee. And I assume roll to the heels on these.
Yes, sir.
Okay, thank you.
There will be another day.
I hope so.
And I have had a request. We have several people here on item 28, House Bill 1181 by Chairman Rudd. We have several people that are from out of state that wanted to address the bill. Is there any objection to taking this bill out of order? If none, it's okay. We will recognize Chairman Rudd.
Thank you, Mr. Chairman. Thank you, committee. Let's see. I have Amendment 1, reference 5537 that makes the bill.
Have the question on the amendment, have proper motion and second on the amendment. We'll be voting to put the amendment that makes the bill on the bill. All those in favor say aye. Aye. Any opposition? I detect that the amendment fails, sir. Sure. Please, Madam Clerk, call the roll. A vote no will be to deny putting the amendment that makes the bill on the bill. A vote yes will be to approve the amendment on the bill. Take the roll.
Representative Boyd? Yes. Representative Freeman? No. Representative Hall?
Yes.
Representative Jernigan? No. Representative Kumar?
Yes.
Representative Marsh? Representative Ramsey?
No.
Representative Sherrill?
Yes.
Representative Smith?
Yes.
Representative Terry? Yes. Chairman, you have 6 ayes, 4 nays.
The amendment is approved to be on the bill, the amendment that makes the bill. You're recognized on the bill as amended.
Thank you, Mr. Chairman. This is the Unborn Child Dignity Act. The legislation strives to extend the same protections, respect, and dignity of a deceased surgically aborted child as granted to any other deceased human being. It would be the responsibility of the mother and the abortion clinic or the facility to provide their expense for the burial and cremation. This legislation does not limit or restrict abortion or access to an abortion facility. It only attempts to guarantee an acceptable level of respect for the aborted child. Working with the Hospital Association, this bill has been amended, and we have excluded hospitals from this bill since they already have policies that reflect this bill. Furthermore, this would make the same level of respect applicable as currently available to pets. Right now at a veterinarian, when your dog or pet dies, the veterinarian is required to ask them how they want to dispose of the aborted pet. I want that same level of dignity applied to a child. And I also have some testimony, Mr. Chairman.
If there are no objections, we'll go out of session, and you can introduce the folks.
Thank you, Mr. Chairman. We have Annette Lancaster, who has traveled here from out of state. And we also, she will be speaking. Also, we have Kelly Lester and Elizabeth Matori.
And ladies, if you would turn on the microphones and identify yourselves for the record.
And be sure and cut your mics on.
Okay. And if you'd identify what organization you're with.
Thank you for this opportunity. My name is Elizabeth Matori. I'm the Vice President of Government Relations for And Then There Were None, the nonprofit ministry founded by Abby Johnson, the former abortion clinic worker that quit the abortion industry. I am a former pro-choice, pro-Democrat Catholic, and these are two of our clients that have quit the abortion industry. And they can introduce themselves.
Hi, my name is Annette Lancaster. I was the previous health center manager of the largest Planned Parenthood in North Carolina, Chapel Hill, North Carolina.
My name is Kelly Lester. I am from Virginia, and I was an employee of a private clinic in the state of Virginia. I also work for And Then There Were None and Pro Love Ministries as well.
And please proceed with your discussion. We're going to give you 3 minutes, but we got plenty of time for questions. So,
Great. Thank you so much. Thank you, Mr. Chairman, and other committee members. Thank you so much for this opportunity to speak with you today on this bill. Again, my name is Annette Lancaster. I was the health center manager at the Planned Parenthood of Chapel Hill, North Carolina. Even though I was not in Tennessee, products of conception rooms are the same in abortion clinics around the world. And just to let you know, products of conception rooms are where the fetus that has been removed from the mother's womb is taken to another room and the workers have to actually piece it back together. The practice of meticulously searching through the contents that are removed from the mother's womb and then piecing back together the fetal remains is exactly the same regardless of where the abortion is being performed. Why, you may ask? Because if any of the remains are left within the mother's womb, that woman will become septic and could die. I was one of the many workers whose job it was to find both arms, both legs, the tiny torso, and the baby's head after each and every surgical abortion, which was about 15 to 20 times a day. What I did, and what is still being done today, is discard these tiny humans in the trash can as if they were garbage. To think that I and other former abortion workers did this on a daily basis and thought it was normal. Even speaking about what we did still haunts me. And I'm shaking right now, so I apologize. There was no appreciation that these babies were human lives. If you're not going to make abortion illegal, the least you can do is not further desecrate these tiny humans and afford them a proper burial or cremation. Offering a proper burial or cremation for these babies will also help improve the mental health of the mothers. Giving this option will decrease the number of suicides that are triggered by depression after an abortion. The fact that we don't even offer cremation or burial as an option to these women just shows the continual dehumanization of what we know is human life. Even the words we use in the abortion industry are purposefully chosen to dehumanize the entire process. We say patient instead of woman or mother. We say POC instead of fetus. We say remains instead of baby. At this point, this is not even an issue about abortion anymore. This is about whether we respect human life. Has not the pandemic taught us the value of human life? Even FEMA is providing funding for families who have lost loved ones due to the pandemic so that they can provide a proper cremation or burial. Why can't we show the same respect to these babies? To be honest, the only reason that we do not offer cremation or burial as an option to these mothers for their aborted babies is so that we can remain detached from the fact that we are throwing away a fellow human being in the garbage can. Thank you.
Would another like to speak?
Kelly?
Sure, thank you. So I not only worked in the abortion industry, but I also am post-abortive. I've had 4 abortions myself. And I can tell you that knowing that that there was a baby that I was aborting at the time when I did it would have helped me heal after the fact. When I realized when I became pregnant and kept the baby that this was indeed a baby that I had aborted when I was in my younger years, the trauma from that I still deal with today. And I know that it's a difficult thing to have a conversation with a woman who is in crisis. These women are in crisis. And so we don't want to have hard conversations with them. But terminating their child does not end the crisis, especially if we don't give them all the facts. Informed consent is something that you do in any procedure, getting your ears pierced, getting a knee surgery. We give informed consent of everything that's going to happen before, during, and after the procedure. We need to give these same things at these abortions. Thank you.
Do we have questions or comments for yes, you're recognized. Oh, okay. I think Paul wanted to talk first. Representative Sherrill or Chairman Sherrill. Go ahead, sir.
Thank you, Chairman. Thank you, ladies, for being here today. And I can understand when you were speaking there, that you were shaking inside. That's really touching. I have a question that you may not be able to answer, but I was thinking about that in these babies. The lives of these children, human life, went into a garbage can. Is that correct?
Yes, sir.
And then they have landed in a landfill somewhere. How many of these babies, lives, children, whatever you want to say about it, how many is in America that's in a landfill somewhere? Would y'all have any idea? Y'all have a...
I would not be able to answer that question.
Really quickly, sir, could Annette speak to how many abortions were performed weekly?
Yes.
So I wouldn't know how many are in the landfills, but I can tell you that on abortion days, we would do at least between 20 and 30, sometimes up to 40 in a day.
Yeah. No wonder our landfills are full with all these lives that we are throwing away in these landfills.
Yes, sir.
I appreciate y'all having the courage and the guts to come and tell us this. I wish America could hear what you ladies had to say today, what we're doing to our people in this world, our babies. And it just touches my heart. But I appreciate y'all very much letting us know today.
Thank you.
Thank you.
Thank you, sponsor, for bringing the bill. Thank you, ladies, for being courageous and being strong. And thank you for sharing your firsthand testimony. And I would just simply say, be very truthful. We're living in a culture where life is being redefined to be cells and to be less than human. And so consider me as someone who will be signing on to this bill as a sponsor, a co-sponsor with you. But also do not soften your voice. Do not allow culture to cancel what you're doing, because that which a culture celebrates is that which we're known for. And we're going to all stand before a judge that's much more greater than this life. So thank you, and God bless you for what you're doing. Thank you, Chairman.
Chairman Terry.
Thank you, Chairman. And I'm going to give you some of my experience on this, and to the other representative's point about shaking inside and what you get. Back when I was in medical school, and this was back in Oklahoma, and you can look it up on the LA Times or Washington Post, there was an abortion provider there that burned 173 fetuses in a field. And that was a big story then. I'm not going to go into details of what I knew about that, but it shook me to my core. So I'm getting choked up thinking about it right now. So I appreciate you coming. Thank you for this. I'm with you on this.
Thank you.
Have further comments or questions of our witnesses? Yes, Chairman Rudd, you're recognized.
I think also, very briefly, Will Brewer with Tennessee Right to Life would also like to say a brief statement.
Okay. No objections, ladies, if you'll make one of those microphones available for us. And sir, come forward and identify yourself and what organization you're involved with. You just push the button.
Thank you, Mr. Chairman, members of the committee. I feel like I'm following the Beatles, so hate to follow that act. Thank you for the honor of allowing me to speak today on behalf of House Bill 1181. The citizens of Tennessee, year in and year out, allow their voices to be heard when they send a pro-life supermajority to the hallowed halls of this building. They express without hesitation or equivocation that this state has an interest in protecting life at all stages and treating that life with dignity and respect. In 2016, following the release of numerous videos from the Center for Medical Progress that exposed the serial trafficking of fetal remains by members of the abortion industry, then Governor Haslam took it upon himself to sponsor and pass legislation that required reporting on the disposal of fetal remains within this state, and that bill also prohibited the sale and trafficking of fetal body parts. Following the passage of that law in 2016, Indiana passed a law that required the burial or cremation of fetal remains. This law was challenged and eventually upheld by the U.S. Supreme Court in the 2019 case Box versus Planned Parenthood in a 7-2 decision. Keep in mind that that decision, the majority vote included Justices Breyer and Kagan in the majority, in addition to the conservative justices. House Bill 1181 seeks to mirror Indiana's law and require the burial or cremation of fetal remains. There is nothing in this legislation that burdens a woman or forces her to do anything that she does not desire to do. If the woman does not choose to decide about the burial or cremation of her child's remains, then the abortion facility is charged with the disposition of those fetal remains. Let me be perfectly clear. These are not kidneys or gallstones or someone's appendix. These are the remains of a human being, and regardless of the decision by that child's mother or father, this human being deserves the dignity and respect in its eternal rest. And those of us that sit here today, I implore you to give these babies their dignity and respect and vote to pass this bill out of subcommittee onto the full health committee and subsequently onto the floor of the House. Thank you.
And sir, please identify yourself and your organization.
Yes, I'm sorry. My name is Will Brewer. I'm the Director of Government Relations for Tennessee Right to Life.
And do we have questions or comments for the witness? If none, we will be going. Thank you, sir.
Thank you.
And thank you, ladies, for your testimony.
Thank you.
We will be going back into session if no objections. And you are recognized, Chairman Rudd.
Thank you. I think they described the bill. It's as minimal. It's not intrusive or discouraging to the woman. It respects the rights of all involved, and I would appreciate passage.
Okay. Representative Freeman, you're recognized.
Thank you, Chairman. So we just heard a couple of different disposal practices here. Can you explain to me what the practice is in Tennessee under current law?
As far as I know, thank you, Mr. Chairman. As far as I know, there are no current law. There are different practices of different facilities. It's my understanding that some abortion clinics break the baby up, grind it up, and flush it down the toilet. Some dispose of it with medical waste, and some put it in the trash bag.
And all of those practices are allowable under law in your interpretation?
As far as I know, there's no law
Chairman
at all
Rudd.
that says what they must or must not do.
Representative Freeman, anybody else have any questions or comments? Yes, Speaker Marsh.
Thank you, Mr. Chairman. And in this bill, who would be, I called one of my funeral directors this week and asked him about his practice on infant funerals, and I asked him about what would it cost. He said, well, we normally try to do them least cost, and sometimes we do it for free. But if you have to pay grave diggers and casket and different things like that, he estimated that it would cost about $1,000 per burial. And so who is going to pay for this, I guess, is my main question in this.
Chairman Rudd.
I asked, when we started this, I asked Representative Alexander what it would cost, and she's in the funeral business. And she said it would be $350 for a burial, $150 for cremation, plus $150 for open burial. And she also said that most funeral homes, especially if it's a small fetus, do it for free. They don't charge anything. Also, in the physical note, there's no significant cost in the physical note. At the bottom, there is a clause that states what morticians, all that would pay. That is simply for the reporting. That's not the cost of the burial or cremation. That is the cost of reporting. This requires a report, an audit to be conducted annually, so they know that the remains have been properly handled, and that states that there's already money in the account for them to handle that reporting.
Speaker Marsh.
Okay, so if it does, it's $350 up to $1,000. Who pays for that?
The bill states that either the mother or the abortion clinic or facility would be paying for it.
Okay, thank you.
I think Chairman Jernigan, you asked for recognition.
I have a quick question. Yes, sir. So, under this bill, then the question is asked to the mother what they would like to do. Is that correct?
Yes.
And so, does the provider give a list of options, or, for instance, if they wanted some of their medical tissue, some of their tissue to go to medical research, or if they wanted to have a cremation, is there a list that's provided to them, a checklist, or who provides the options, I guess?
Chairman Rudd.
This bill directs the Department of Health to provide a form. That form would go through the system. They would be provided the options, and they would choose it and sign it or refuse to sign it. In that case, the abortion facility, if the mother did not want to have any part of it and walked out, then the abortion clinic would have to fill out the proper paperwork and conduct the disposal of the remains properly.
Chairman Jernigan.
So, okay, so the Department of Health will determine the criteria of the options, correct?
Yes, we've made it permissive. We provided a framework for the Department of Health to go by and left it up to them to formate those particular rules. Those rules are also based loosely off of what we already don't do, off of Indiana's past law.
Chairman Jernigan.
In India, how long has that law been in effect? Do you know?
Chairman Rudd.
I believe that's been within the last 2 years.
Okay, thanks, sir.
And Ohio passed one, I believe, just this past year or this year.
Representative Hall, you're recognized. Pardon me, Chairman Hall. We've had the question called for. Any objections? If none, we'll be voting to send this bill as amended to full committee. All those in favor say aye. Aye. All those opposed? No. The ayes have it. We're back in the full committee.
Thank you.
Further comments or questions? The remaining roll bills and bills on the calendar will be referred to next week. So I will stand for a motion to adjourn. Hey, Miriam.